Study Session 2: Mental Retardation, Intellectual Developmental Disorder (IDD). Introduction. IDD was formerly known as mental retardation in DSM-IVTR, but it was not preferred due to stigma. It can be described as a condition of having an intelligence quotient (IQ) measured as below 70 to 75 and significant delays or lacks in at least two areas of adaptive skills. Mental retardation is present from childhood. Study session will focus on intelligence quotient, diagnosis of mental retardation and conduct disorders (CD). Learning outcomes for study session 2. When you have studied this session, you should be able to 1. Explain the meaning of intelligence quotient (IQ), discuss diagnosis of mental retardation. 3. Define conduct disorders (CD). 1. Meaning of intelligence quotient (IQ). The American Association of Intellectual and Developmental Disabilities (AAIDD) defined intellectual disability as being characterized by significant limitations, both in intellectual functioning and in adaptive behavior as expressed in conceptual, social, and practical adaptive skills, and this disability begins before age 18. The American Association of Mental Retardation (AAMR) and DSM-IVTR both define sub-average intellectual functioning in terms of a score on an individualized intelligence test, a standardized measure for assessing intellectual ability. Mental retardation is coded along with personality disorders on Axis 2 in DSM-IVTR in order to call attention to possible Axis 1 mental disorders. The Axis 2 placement also reflects the fact that significantly sub-average IQ is enduring. Intelligence tests yield a score called the intelligence quotient or IQ, the test's rating of an individual's intellectual ability. Intelligence is conceptualized in terms of an intelligence quotient (IQ). Defining intelligence can be controversial, and definitions and measures of intellectual ability have changed over the years. Early versions of intelligence tests derived an IQ by dividing the individual's mental age by his or her chronological age. Mental age was determined by comparing an individual's test results with the average obtained for various age groups. Contemporary intelligence tests have abandoned the concept of mental age and instead have adopted the concept of the deviation IQ. According to this theory, intellectual ability follows the normal distribution in the population, a bell-shaped frequency distribution. The individual's IQ is determined based on how the person scores on an intelligence test relative to the norms for his or her age group. Intelligence tests are normed to have a mean average IQ score of 100 and a standard deviation of 15. One potential problem with the deviation IQ is that IQ scores in the normal range are rising across generations, a phenomenon known as the Flynn effect, named after James Flynn, who first noted the trend. Both the AAMR and DSM recognize that intelligence is more than IQ score. Thus, they include adaptive behavior as a part of their definitions of mental retardation. One's level of adaptive functioning is important. Adaptive functioning can be described as how effectively an individual copes with ordinary life demands and how capable he or she is of living independently and abiding by community standards. The AAMR suggests that adaptive behavior includes conceptual, social, and practical skills. Conceptual skills focus largely on community self-sufficiency and incorporate communication, functional academics, self-direction, and health and safety for DSM-IVTR. Social skills focus on understanding how to conduct oneself in social situations and includes social skills and leisure from the DSM-IVTR list. Practical skills focus on the tasks of daily living and include self-care, home living, community use, health and safety, and work from the DSM-IVTR. Adaptive skills are difficult to quantify. As with the definition of IQ, the AAMR defines a significant limitation in adaptive behavior as a score that is 2 standard deviations below the mean on a standardized measure of adaptive behavior in conceptual, social, or practical skills. Diagnosis of mental retardation. In 1866, the British physician Langdon Down first described a subgroup of children with mental retardation who had a characteristic appearance. Down's classification helped subsequent scientists to establish a specific etiology for what we know as Down syndrome. The creation of IQ tests in the early 20th century also greatly furthered the classification of mental retardation. The AAMR has set the IQ score cutoff at 2 standard deviations below the mean, which is 70. Today, mental retardation can be classified according to 2 different criteria. One criterion is based on IQ scores. The other is according to known or presumed etiology. The AAMR uses a multi-axial diagnosis of mental retardation in which health, including etiological factors, is rated on a separate axis. A more controversial aspect of the AAMR subclassification is the ratings of 4 levels of intensity of needed support across 9 different areas of functioning. The goal in rating support intensities is to acknowledge the diversity of skills and needs among people with mental retardation, both as people and for treatment planning. In adopting the support intensities approach, AAMR abandoned a long tradition still followed in the DSM-IVTR of dividing mental retardation into 4 levels, based primarily on IQ scores: mild, moderate, severe, and profound. Degrees of impairment, DSM-IV. Mild MR IQ of 55 to 70. People with mild mental retardation typically have few, if any, physical impairments, generally reach the 6th grade level in academic functioning, acquire vocational skills, and typically live in the community with or without special support. Applies to about 85% of persons with MR, typically not identified until elementary school years, and there is overrepresentation of minority group members. Moderate MR IQ of 40 to 54 applies to about 10% of persons with MR, usually identified during preschool years. Applies to many people with Down syndrome. Severe MR IQ of 20 to 39 applies to about 3% to 4% of persons with MR, often associated with organic causes, usually identified at a very young age. Profound MR IQ below 20 or 25 applies to about 1% to 2% of persons with MR, usually identified in infancy, always associated with organic causes, and often co-occurs with severe medical conditions. Motor skills, communication, and self-care are severely limited, and constant supervision is required in the community or in institutions. Etiology of intellectual developmental disorder. After defining IDD, let us now look at the etiology of intellectual developmental disorder. Many organic causes have been discovered, but majority of cases cannot be explained, especially for mild mental retardation. The 2-group approach: 1. Organic mental retardation. 2. Cultural familial mental retardation. Organic mental retardation. This includes chromosome abnormalities, single gene conditions, and neurobiological influences. Causes of mental retardation include fetal alcohol syndrome and fetal alcohol effect, brain damage caused by the use of prescription or illegal drugs during pregnancy, brain injury and disease, and genetic disorders, such as Down syndrome and Fragile X syndromes. Syndrome is indicated by weakening or breaking on one arm of the X sex chromosomes, and it is transmitted genetically. Not all children with the Fragile X abnormality have mental retardation. Cultural familial mental retardation includes family history of mental retardation, economic deprivation, inadequate childcare, poor nutrition, and parental psychopathology. Neurological factors: Down syndrome, chromosome trisomy 21, an extra copy of chromosome 21 making a total of 47 instead of 46 chromosomes. Fragile X syndrome, mutation in the FMR1 gene on the X chromosome, the most common cause of inherited MR. Prader-Willi and Angelman syndromes, both associated with abnormality of chromosome 15, believed to be spontaneous, genetic, birth defects occurring around the time of conception. Recessive gene disease, inborn errors of metabolism, referred to as single gene conditions, can result in syndromes such as PKU. Phenylketonuria is caused by abnormally high levels of the amino acid phenylalanine, usually due to the absence of or an extreme deficiency in phenylalanine hydroxylase, an enzyme that metabolizes phenylalanine. Children with PKU have normal intelligence at birth. Inheritance and the role of the environment. Heritability of intelligence is approximately 50% major. Environmental variations can affect cognitive performance in children from disadvantaged backgrounds. Prenatal influences may be mistaken for genetic when they are actually environmental. Social and psychological influences, deprivation of physical and emotional care and social stimulation, particularly influential. Treatment of intellectual development disorder. Child's overall adjustment is a function of parental participation, family resources, social support, level of intellectual deficit, temperament, and other specific deficits. Treatment involves a multi-component, integrated strategy that considers children's needs within the context of their individual development, family and institutional setting, and community. Prenatal education and screening may prevent some cases of MR. Psychosocial treatment intensive, child-focused, early intervention efforts are very promising, particularly for disadvantaged children. Optimal timing for intervention is in the preschool years. Residential treatment. Small to medium-sized community residencies. Behavioral treatment. Behavioral techniques include shaping, modeling, graduated guidance, language and social and motor skills training. Methods of successive approximation to teach basic self-care skills in severely retarded, e.g., holding spoon, toileting. Cognitive treatments. Cognitive behavioral techniques such as instructional training and metacognitive training, and also problem-solving strategies. Family-oriented interventions help families cope with the demands of raising a child with MR. Conduct disorder is classified by age of onset and severity. Adolescent onset type is defined by no behaviors of conduct disorder until after 10 years of age. Least likely to be aggressive, have more normal peer relationships, less likely to have persistent conduct disorders or antisocial personality disorder as adults. Childhood onset type involves symptoms before 10 years of age, physically aggressive, disturbed peer relationships, more likely to have persistent conduct disorders and to develop antisocial personality disorders as adults. Severity classification are mild, moderate and severe. Mild: few conduct problems causing minor harm to others. Lying, truancy, staying out late without permission are common. Moderate: number of conduct problems increase as does the amount of harm to others. Vandalism and theft are common. Severe: many conduct problems that cause considerable harm to others. Forced sex, cruelty to animals, weapons, burglary, and robbery to mention a few. Etiology of conduct disorder. Genetic factors. Irritability likely plays a part. Meta-analysis of twin and adoption studies suggests 40 to 50% of antisocial behavior is heritable. Genetics has a stronger influence when behaviors begin in childhood rather than adolescence. Also, genetics and environment interact. Abuse as a child is most likely to development of CD. Neurobiological factors. Poor verbal skills, difficulty with executive functioning, low IQ, low levels of resting skin conductance, and heart rate suggest lower arousal levels. Psychological factors. Deficient moral development, especially lack of remorse, modeling and reinforcement of aggressive behavior, harsh and inconsistent parenting, lack of parental monitoring, cognitive bias, neutral acts by others perceived as hostile, peer influence associated with CD, rejection by peers leads to affiliation with deviant peers, sociocultural factors, poverty, urban environment, living in poorer neighborhoods rather than race. Treatment of conduct disorder. Family interventions. Family checkups associated with less disruptive behavior. Parental management training, e.g. teaching parents to reward prosocial behavior. Multisystemic therapy, deliver intensive community-based services.